Hello, everybody. Welcome to the first GHP Brown Bag of the year. My name is Jacqueline Barber. I'm a member of the department, and I'm delighted to see so many of you here today for what I'm sure will be a very interesting discussion. Before I introduce our speaker, I would just like to read the disclaimer that we have to make before every Harvard meeting these days. So I'm just reading the text in front of me. Speakers' remarks are based on their own scholarship and experience. As such, they speak for themselves and not for Harvard. And as a reminder, all our panelists do not speak for the university. They've been invited to share their personal perspectives and not to speak for Harvard. Yes, I need to repeat it again and again. Okay. So let me introduce our very eminent speaker, who is sitting behind me. So Lia Tadesse Gebremedhin is the executive director of the Harvard Ministerial Leadership Program and a visiting faculty in our department at the Chan School as of March of this year. She was the Minister of Health of Ethiopia for 4 years between March 2020 and February 2024. After serving as State Minister of Health from November 2018. So if anybody who knows anything about the history of Ethiopia, that was an extraordinarily difficult and complex time. So being in a leadership position then must have really quite a lot of skill. So as a minister, she was spearheading the COVID pandemic response, which is what she's going to talk about today, and was also responsible for responding to other emergencies related particularly to conflict and drought. And she was credited during her tenure with not only building the health system, but also forging strong partnerships across sectors. Her bio is very long and I won't read it all. Suffice it to say that she has many accolades and has really performed a lot of very important reforms within complex health systems. And Lia, we are delighted to welcome you today. Thank you for joining us and making your presentation.
Thanks so much, everyone, and also the department for giving me the opportunity to present on the experience of the preparedness and response of Ethiopia. So also like to welcome everyone here in this online. So primarily, as you see on the topic of discussing, sharing the experience of how country and also myself as a minister at the time led the pandemic preparedness and response, but it's also meant to really share how the investments we make in health systems before any crisis would play out either positively or negatively, and also the key message of how we use the difficulties in such crisis towards really building resilience. It's a famous quote of the Northwest crisis. So it's also sharing what we did and what will also be done in the context we live in globally with numerous crises and happens. So I'll have a brief background. This will be my outline, but I'll be spending most of the time talking on the different pillars of the pandemic preparedness and response, including the interventions that were done towards not just mitigating the emergency, but also building a stronger health system. But before I go there, I just wanted to introduce a little bit background of my professional journey. My background is I'm a physician. Since as early as I remember, I wanted to be a physician. My father was a PhD in entomology, and my mom was a teacher, but they were very much into education, but I had no one medical background. So I don't really know how I was inspired, but I used to tell my dad, I want to be a doctor like him, but a real doctor. So in medical school, in my clinical rotation, I was trained in one of the universities in the southwest part of Ethiopia, which had a huge catchment population and was serving also in remote areas. In my university, I was seeing so many complications in my first OBGYN rotation, including women with obstructed labor, ruptured uterus, with our interventions, which was really a life and death issue. So that really inspired me to move into OBGYN and reproductive maternal health career. And I had never thought I would leave that clinical work because that was really I was passionate about. But it was, although I was in many ways interested in always being drawn into health system improvement, but it was one speech that really made a turning point in my career, where I presented on a National Society of OBGYN annual conference, which reached to the minister at the time, who was Dr. Tedros Adhanom, Director General of WHO, who after hearing that or reading the speech I presented there, summoned me to come and said you should join some in the new reforms that the ministry is doing. So I was assigned to lead a teaching one of the biggest hospitals, which was to become a teaching hospital. So I went into leadership in hospital reform and academia, and that led into a series of activities into growing passion of the health system strengthening. So, but fast forward, I became Deputy Minister of Health in 2018, and in December 2019, I was an acting minister because of my predecessor had left at the time, and was preparing for what's not knowingly, of course, not knowing what was to come, but we were in the preparation of preventing the COVID emergency. So March 11, the global pandemic was announced, and March 12, I was appointed as minister. And that same night, we had our first case of COVID positive diagnosis. So the last 4 years was leading the COVID my main entry point, but as a country, we were facing different challenges, as mentioned earlier by Jackie, like conflict and climate crisis. So leading in crisis may look like a thing, but I think I would say it was a privilege to serve in that role and also an opportunity. And then to just set a little bit of context, Ethiopia, many of you may know, but it is in the eastern part of Africa, and with the current estimate of about 170 million population, very diverse topography, culture, diverse ethnicity, and it's a very young population of about 70% under 29 years, and children under 15, under 5 years are also about 50%. And this is also important in the context of the pandemic. Our older age group above 65 is only about 3.5%. Fertility rate, the current is about 3.9. This is a significant progress from where we were in 2020, which was about 6.5. And this is credited to most of the work done through our primary health care and community health program to really improve access to family planning. This is the current under 5 maternal mortality. And it's a 3-tier health system, but the largest base being the primary health care system, which includes our community health program, but also primary health care centers and primary hospitals as one unit. So I will go through the main, what I call the main pillars of our response, and see in terms of that we need to also have sustainable impact with the response. So the first one is really the how we were coordinating and what the governance and leadership looked like for the response. So the first step, of course, what we did as the Minister of Health was to activate the National Emergency Coordinating Center. This was around end of January 2020, before it was a pandemic. And this, we were able to do this because of some of the investments done around 2016 because of the Ebola outbreak, and to prepare for that, there were investments made in having stronger national public health institute and emergency coordinating centers, both at national and sub-national level. But then we also had to establish different task force that really coordinated this, which included from the higher level led by the Prime Minister, and then a disaster risk management council led by the Deputy Prime Minister. But the main responsibility, of course, was lying on the National Public Health Emergency Task Force led by the ministry that I was chairing, because this task force was responsible to give the right evidence board decision for the ones at higher one, and also give direction for the technical and sub-national task force that were implementing those decisions. So this was really critical in terms of having one aligned decision-making process, timely decision-making process, which also was important in creating trust and credibility in the community, because we are sending out consistent messages, but also it's really key in terms of mobilizing resources and joining forces with different sectors. And with that approach, so the first step that was done, one of the key pillars was the non-pharmaceutical interventions, which included, of course, risk communication and community engagement. And with the governance platform, the initial step that was announcing a state of emergency that was announced by the cabinet ministers. And this was not a full lockdown, but to institute restrictions, different restrictions. So schools, universities were closed 3 days, actually even before the state of emergency, 3 days after we had our first case. Bars were closed, mass gatherings were banned, and religious institutions also were closed. But the government gave airtime for at least the mainline religious institutions, so that they can stream their services on TV. The civil service continued to provide care, but became partially remote, where older age and also those with chronic illness were allowed to stay at home. Mandatory quarantine was instituted. This is for both contacts of cases and for international travelers who are coming here. So this was, of course, one of the key elements of the response, was that it really required agility in terms of course correcting every time. And doesn't mean all of this we were able to continue doing those. You may see at the bottom that some of the media critics say the government does not have the resources to do this, but it was unknown. So the decision-making process was always balancing on the unknown and the known and quickly course correcting. So we were using schools, hotels for quarantine, and international travelers had to do 14 days quarantine in designated hotels, and universal masking, social distancing were all part of the measures. So, but to make sure that the community is adhering to this, the risk communication aspect, including engaging communities, was really critical. So daily press briefings, I was giving daily press briefings, and at some point I had to ask the National News Agency to give me full-time journalists who sit next to my office with their gadgets, so that I was able to do that easily. So, but this was important for building trust with the community and adherence. And of course, social media and using volunteers as well was really critical. These were the one you see up, Red Cross volunteers, thousands of youth across the country who are really mobilizing communities on adherence of these measures. And we also used our existing community health workers to go house to house with some surveillance to ensure if patients were sick. I mean, there were patients to teach them, but also identify cases, like they would at least try to screen what they can. But this was not only to identify COVID cases. One of the things I'll talk later is people were with chronic illnesses were staying at home for fear of COVID. So this is also to identify those who were staying at home. So there was intensive media engagement in this regard. And the other pillar was the surveillance, contact tracing, and the lab testing. When we started first, when the pandemic first happened, we did not really have the capacity to test. We were even sending samples to South Africa to get results, but we had to quickly then look at what we have. We did have PCR testing, which was not used for COVID, it was being used for other purposes. So we had to map out those and initially start in the National Public Health Institute, but then quickly roll it out to other public health labs and research institutes and universities. So we not only use those in hospitals, but we have to use centers. So within 10 months, testing capacity increased from 0 to about 65 sites across the country, and later to about 82, which included private centers as well. And we also, it was important to know that we also involved other sectors like the agricultural sector, research institutions also to use, to expand the testing capacity. Of course, later on, rapid testing was introduced so that it made it easily accessible, but we also used this challenge again to start a genomic sequencing capacity for the country in collaboration with global partners like WHO and others. Intensive contact tracing was initially important to really make sure we contained it, but again, as I said earlier, this is part of what we were doing in terms of course corrections, where it was not really feasible to trace all the contacts that that was in the initial phases of the pandemic. Those are important steps. Next pillar is what we did with those who were diagnosed with COVID. So we had 3 types of facility readiness for managing COVID cases. The first is to have dedicated COVID centers, which were only dealing with COVID. So we had to shift some of the facilities to only provide COVID service. The second was to shift some non-health facilities into either quarantine or treatment centers. So some schools, because schools were closed, we used some of the schools, meeting halls, sports centers, which were shifted to give this service. The picture you see here down is the largest convention center we have in Addis, which was shifted into the biggest COVID center. And for this, of course, we had to do a lot of infrastructure modifications to it included a 40-bed ICU and then other severe cases. It was about an 800-bed facility. And a series of health worker trainings needed to be done. The biggest challenge was really shortage of protective equipment and supplies because of the global supply chain disruption that was there. And at least for immediate interventions, we are working with the private sector, even textile factories, to make shift what they were doing to start producing at least PPEs in as much as they can, and start some local capacities. We were initially again admitting all COVID cases. And this is where out of this later on about the evidence for decision making that was key to our decisions. So again, we have to then move to only admitting moderate to severe cases and have a guideline on home isolation because that was not feasible. So one of the publications in the first COVID centers, 6 months of the case fatality after we moved to only admitting moderate to severe cases was about 11.4, with those with comorbidities were significant predictors of mortality. But again, to ensure where we reduce the mortality, but at the same time build the health system, what we continue to do was invest really on the emergency capacity of our facilities. We had a national oxygen roadmap because that's one of the key shortages we had as a country for emergency care, but we are really far behind in terms of access to oxygen. So using the government funds and donor funds, we work with several partners to expand oxygen plants in many facilities across the country. So it was around 3 years later, it was almost 10-fold capacity, and hospitals with ICU were only about 55 across the country, and that also doubled. But so in terms of really tracking mortality, ensuring that we reduce the mortality, the data we had was those who were being confirmed and admitted in facilities. But in a country like Ethiopia, where we don't have these registries, which is a very limited days registry that we have, and a lot of this happen in communities, we had to do alternative ways of checking data. So one was burial site tracking. So this was actually helpful because we had some sites we were using for HIV, which we reactivated with Addis Ababa University to track 66 funeral sites, burial sites, to see if there is spikes. We may not know the causes, but if there are spikes, that should suggest to do more or so 6 months into the pandemic, there were in some areas significant spikes, which showed, which came with the Delta variant, and then we had to again expand the capacity of moving some of the facilities to increase admission, because having access to admission was really critical in terms of reducing mortality. So in 2 years, this is from the confirmed cases. The data you see below, it does not mean that it's actual mortality, but it's from the confirmed cases we had, which was around 470,000 cases by 2 years. This was a mortality rate of around 1.6%. Health workforce, of course, a key backbone for the health system, and we estimated that there would be a need of about close to 45,000 more health workforce to really mitigate, based on the modeling, which was not really giving accurate data, but that it was not possible to really to have that kind of workforce in a short time. Fortunately, the ministry and the government had been investing on training health workforce at different levels, so there was a larger number of workforce, which another challenge was there was huge unemployment of health workers. So we try to use again this challenge as an opportunity to bring more health workforce into the system, both to mitigate the response, but also create also employment opportunities. So we had this number is from various actors, including NGOs and others who helped deploy this amount of health workers, but even the ministry itself was able to recruit about close to 5,800 workers. And training, of course, providing critical care training was done, but this was a challenging time for all frontline health workers, as we know. So I was occasionally holding online live social media discussions. Sorry, this is in Amharic for many of you don't see, but it's an announcement that I would hold a live media discussion, and then they can post their questions there. So I may not be having all the answers to the questions, but it's to be accessible and then see what the concerns were, and to also explain what we are trying to do. And some even stayed in hospitals for many months without going back to their families. So we're using some volunteers, health workers, to provide psychosocial support to the workers. And at the end, we also try to do a national recognition for service provided by health workers. Continuity of essential services. So in cases, in any public health emergency like a pandemic outbreak or other crisis, a big challenge is not always what happens to the direct impact of the pandemic or the emergency, but the indirect impact of disruption to other services. So because of different reasons, fear of contracting COVID, and also even the system being trying to cater more towards the emergency, there was initial decline of visit of essential services. But within a month, we quickly actually tried to institute set of interventions through an interim guideline for non-COVID essential services. We actually established a task force that was responsible for continuity of non-COVID essential services, which was working with the COVID task force. And some measures were instituted to help the continuity. Of course, communicating to the public that services are being provided and they should come was one of the things, but also being open in some of the clinics for additional working hours, especially the chronic care clinics. Teleconsultation was also started for HIV and others like TB and chronic care and CDs as well. Multi-month dispensing for chronic care, and also trying to monitor the data of chronic care and also other essential services like maternal vaccination immunization programs weekly rather than what we used to do monthly tracking. So as you see in the upper ones is publication specific for Ethiopia, where you see a sharp decline in the first month of April, and then soon after the pandemic, and then quickly regain to at least relatively. It was still continuously a little lower than 2019, but the decline was back to where it was. Back to relatively low. And another analysis of 10 countries that was published in Nature Medicine showed, which included Ethiopia, showed most of the health systems were really disrupted for a longer time, and like Ethiopia and South Korea actually, which represented two extremes, were among those least affected by health service disruption. So it does show you that it may not necessarily mean it's related to the development of resource issues, but also about the type of interventions that were instituted. Vaccines were a great opportunity in terms of the pandemic, but initially Ethiopia was able to receive only 2.2 million doses for such a big country, so we had to use a phased approach. So we started with healthcare workers, which were frontline, and then continued to older age and those with chronic illnesses, displaced population, and that's how we continue to expand. But the challenge was the global and continental mechanisms that were there for us, but they faced challenge. So we were not able to access quickly the vaccines that was needed. So this failure to get subsequent doses really created a loss of momentum from the community, which were initially eager to get it. So a lot of effort was required to really continue the next phases. So the first 6 months, even after we got more doses, we were able to only vaccinate about 5.4 million. But with a series of media strategies, using trusted figures like religious leaders, like you see here on the picture, modeling, taking the vaccines to media, and various outreach campaigns actually for providing the vaccines rather than just waiting for people to come to the primary care centers. Then we were able to really enhance the vaccination and reach to about 56 million received at least one dose, and at least about 45.1 million were fully vaccinated. And we also used, again, this opportunity to enhance, again, the capacity of the health system. Ultra cold chain was not there, but we had to introduce vaccines like Pfizer to vaccinate the younger age group. So we also use this opportunity to enhance our ultra cold chain capacity. Evidence-based decision making was really critical in terms of the decisions we made, but was not easy. It's challenging in terms of getting the needed data. The first step what we did was to include lab data indicators into the existing national health information system, the district health information system, so that it's being communicated to the public as well, but also is helping us for making real-time decisions and assure quality. But also additional data like surveillance data was also used. But we also had to use, we were also supported by different advisory groups. One of the key pillars in terms of what was supporting us in what the ministry did. So this, just to highlight the main ones. So we had from out of 11 health professional associations, National Health Professional Advisory Council was formed to give us the evidence that we needed to make decisions. There was a full-time committed clinical advisory group, which was specifically advising on the clinical measures that we need to do, and even preparing the national clinical guidelines for COVID to be in place. And the other one was really having a research and national research task force, which worked with universities to generate data. Some of it may not be as the above two that I mentioned are primarily we're looking at the global data to really generate evidence and support the ministry, but the task force was primarily tasked to actually generate local evidence. And this was really important in terms of the decisions we made, and actually looking at what the research task force did, we saw that there was a gap in the ministry to have this kind of structure. So we later established a new unit within the Ministry of Strategy and Policy and Research, which can not necessarily produce the researches, but about priority setting and research agenda setting for the health sector. So in all the different pillars I mentioned, we were trying to do different interventions which can respond to the emergency at the same time can sustainably build capacity of the system. So, but also we're also doing interaction reviews and also deciding what steps we need to take in terms of having broader interventions. So one was to reorganize our National Public Health Institute based on the experience we've had to make sure that because there were some fragmentations in what we did within the ministry and within the Public Health Institute, so that we made sure we have a stronger Public Health Institute by having aligned interventions within the organization. And the other was instituting this early detection, notification, and response 717 principle, which came from Tom Frieden and colleagues, as you may all know. So this is to help us routinely monitor where our system is in terms of notifying early detection, so that this targets, just to clarify, is it gives a target for any health system should detect emergencies within 7 days, notify within 24 hours, and then respond within 7 days. So doing analysis and seeing where the gaps are in terms of, it could be for any measles outbreak, it could be for different emergencies. So we have instituted this monitoring system. The other was really service integration. In the initial phases, as I mentioned, we're having COVID centers separate from non-COVID centers, but we needed to have an integrated approach because patients who come with COVID would come with other chronic illnesses. We needed to have other services available. So how do we manage those as part of integrated service? That's how we later moved the different standalone centers into integrated care. But also, it also showed the interventions that we needed to continue investment on integrated care beyond the pandemic, but for all emergencies. This was actually a emergency resolution that Ethiopia was co-leading with other countries at the World Health Assembly in 2023 about integrating emergency, critical, and operative care, which will continuity of care and reduce morbidity and mortality. And the other is primary health care has been still the pillar for universal health coverage and will still continue. But one of the things that the pandemic has shown as a gap was our primary health care system was not fully equipped to comprehensively address the challenge of emergency and other priorities that it was already doing, but also the emerging challenge of NCD. So this approach of investing on primary healthcare and also particularly an epidemic-ready primary healthcare has been one of the investments we are doing, at least having one such center per district. I would not, the last two are really broad topics themselves, the supply chain and the financing aspect, but these were other key pillars that we were really working on in terms of having, as not just as a Minister of Health, but as government, incentivizing organizations to expand local pharma industry. But we also were able to launch the first vaccine manufacturing initiative, which is still underway. Health financing, similarly, is a really broad topic, which I will not go into, but one of the initiatives we started based on the gaps we have seen in terms of the health financing, that the resources we had to mobilize during the emergency was about establishing a resilience and equity health fund that can mitigate such challenges. So to come to the to finalize with the broader context, I think the current new normal we are seeing across the globe with so many emergencies happening, as you can see on the different pictures, could be either with conflict, climate crisis, violence, continued humanitarian crisis in outbreaks like the mpox. Many countries across the globe are facing this challenge, which is becoming the new normal. So we need to continue then to innovate on how our health systems can really be resilient to resist shocks from such kind of crisis and then protect the vulnerable communities that they serve. So this will be my last slide to conclude as now looking ahead within the family of the Global Health and Population Department in the broader School of Public Health. As a public health practitioner, I hope to again continue sharing my hands-on experiences and contributing to developing future global health leaders when you'll be here in the room in different areas like health system strengthening, leadership, and maternal and reproductive health and more. Also I hope to engage in different research collaborations again to continue to accelerate progress in global health. And I also hope to enhance partnership opportunities between the Harvard Ministerial Leadership Program and the Global Health Department and the school, and hope to continue engaging also globally to contribute to shaping the future of global health with colleagues like William McDoing, the Lancet Commission, others, Quest Network. So thank you so much for this opportunity once again. Forgot to thank, this is thanking all on the front line. This was just a Guardian publication of a photographer who took account of the first COVID center. Well, he was with them, and this is on the publication. You'll see it in my references. Then to many who were part of this, and of course my own family. Thank you.
Thank you very much, Lia. This is a fantastic presentation. I wonder if I could abuse my position as moderator to ask the first question while people are preparing theirs. And what I wanted to ask you, I think what you presented and what was so fascinating was this really holistic, multi-dimensional response to this, you know, working on so many different aspects of the problem. I found that really impressive. I work on migration, and one of the terrible things about the COVID pandemic was that it led to a dramatic increase in xenophobia, and in many cases it led to closing of borders, you know, really for non-medical reasons. You said that I think you didn't say anything about closing borders. You said though that there was mandatory quarantining. My sense is that a lot of the kind of borders in Ethiopia are pretty porous. You know, there isn't a kind of effective or very decisive border control like we're used to in some of the global north countries. So I wondered if you could say a bit more, both about how the quarantining worked and whether there was any danger of xenophobia and kind of like lack of trust developing because of these measures against people who are perceived to be outsiders. Maybe just answer my question and then we'll, yeah, thank you.
Thank you. That's a very important question because that was one of the big challenges. Indeed, monitoring the border from the airports was not a challenge. It was not a big problem, but the borders, the land borders were definitely porous. So it was not something we can say we were able to control properly. But in the main borders where we had entry points in the different borders, we did have this set up these quarantine centers. So it of course logistically itself was a big challenge because it required to deploy a lot of workforce in the different areas, and most of the time the challenge was really related to resource issues and people really not wanting to stay in the quarantine, and that creates problems because this is being enforced. So there is a follow-up mechanism with even the legal forces. So that was a big challenge. But overall, logistically was also a big challenge because especially on the land borders, the facilities we had were very limited. So monitoring everyone was a big challenge. So it was not really something to say was 100%. What we did on the major airports was one we can say was successful, although still resource intensive.
Thank you. Yeah, go ahead.
Thank you very much for the presentation. I was thinking about what do you think of how elastic health systems are? Because during the COVID pandemic, I was working in India in the state called Assam, where I was heading a district which had around 11 lakh population. So your presentation took me to those days when I myself was isolated from my 1-year-old baby for 45 days. When I came back, she was doubtful it was me with all the mask and everything. Then it was a crisis. We didn't have enough number of health workforce and the systems infrastructure itself. Just like what Ethiopia did, India also did a lot of investment. And now, then soon after that, I became the mission director of the National Health Mission. So then I had just too many resources at my disposal, including staff we had recruited at that time. And then we had to figure out a new plan altogether. So it was more like expanding and then trying to come once again back to the normal situation. So what do you think? How elastic is health system itself?
Yeah, that was another important challenge which I didn't have time to talk to, but you remember I said we deployed a large number of workers, and initially, of course, the Ministry of Finance was proactive in giving us additional fund, which comes even like that, and we had actually employed them initially on a temporary basis, on a contractual basis, but these are workers now who have been on the front line with COVID, and saying to them, now we don't need you is really not possible, not only for the health system, but really that is not the right measure. So we try to, again, continue mobilizing resources and then use them within the system in ways that they can be, again, beneficial. Because, again, it's not because we had enough healthcare workers that they were not employed. It's also all about issue of not having adequate resources. So we went into an agreement with some national offices, health bureaus, that we would provide bridge funding, and then they have to find funds and then put them into the regular payroll or as a civil servant. So within 3 years, we were able to include them, almost 98% of them, into the workforce. There are a few that we were not able to. So it was challenging, and this is the case not just for health workers, but other issues. But that's why when we were investing in terms of the emergency care, the critical care, we were trying to put most of the investment in the existing facilities so that they can shift to caring for other services.
Yeah. Thank you so much for your presentation. I have 2 questions. One is very similar to Professor Bella's question. You mentioned that you all engaged in cross-border surveillance. So I was wondering, like, what does that look like politically? How did you work with kind of surrounding nations, if that was kind of what that entailed? And then my second question, I understand that Ethiopia went through the joint external evaluation process in 2016 and then in 2023. So I was wondering, like, this 2023 version, what did that look like? What were some challenges? Who was involved?
So the surveillance, it was not pertaining to any specific countries, all travelers. So it does not really discriminate or say those countries are the ones with this. So it was for everyone entering. Initially, it was about quarantine. Then later, it became about having a COVID test result. So it was for all countries. So and then we were working with Africa CDC, the Africa Union, also to help up some digital platforms in that regard to make it easier, to make it facilitated easy for the travelers. We all know most of us are faced with this challenge of testing for travel. But so we were working collaboratively, I can say, and since we did not make it country specific, we didn't have those challenges. I think on the evaluation, probably we can talk more later, but definitely that there are different shifts that are there in the system. One biggest being definitely the pandemic and what it brought, but also the other epidemiological shifts that are there in terms of other reports we had, like the Lancet Commission report on mortality, which showed really the increased mortality from non-communicable diseases and injuries, which has really surpassed even 50% for our case for our country. So all that showing the needed shifts of interventions we have those are the primary healthcare system and other.
Yeah.
Thank you for the presentation. You highlighted a few parts of the health system that were critical for the response, and some of them stood out to me as being chronically underfunded areas, so lab systems, data systems, et cetera. And so I'm curious, coming out of the response, how you may have been rethinking the financing for those like kind of health system strengthening pieces of the health system that are not as well funded typically. Like, how do you create that resilience?
Yeah, there's no easy answer to that. Definitely with the limited resources and the experiences with the response, it has shown us that what the areas we need is investments in many of the key areas as you mentioned. And I'm happy that one of our colleagues from the EPHI is also here, Tedros. So we have been working, one of the investments we had, one of the things I did not speak on the extensive resource mobilization that we have tried to do through not just government, but also global financing mechanisms like the World Bank and the Global Fund. So what we are using, although they are coming for COVID emergency response, a lot of it we had insisted we are going to use it as investment in the systems. So the primary healthcare units I mentioned earlier that we are investing on, but also the lab systems, the data systems, we continue to invest on those. Although still not enough, those were the areas that we are mentioned, the critical care emergency, which I mentioned earlier. So we know that we were not going to get it globally or locally that kind of funding once the pandemic goes and we have seen it decline. But so using that opportunity to really create lasting investments of that.
Marcia and then the colleague.
All right, so I have two questions. One is, you mentioned the media engagement and the daily press briefings. Can you say something about how much this was able to mitigate misinformation and disinformation that was something that affected most countries? And the second question is there anything in particular that you wish it was done different or better now that you have the benefit of being able to look back, but something that can stay as a lesson for a future one, and it's likely going to be a future one?
So the misinformation, yes, the media, the communication piece, I mentioned my daily briefings, but there were various kinds of communications that we do. Our advisory groups, different professionals, we line them up for different media briefings or interviews on radios or TV. So that the community is hearing also from professional voices, not just from me as minister or others from the government, but also from professionals, which was really critical. But all was consistent. So we had guidelines and how we are doing. So there was no inconsistency in the messaging. So for the most part, also there are different research papers documenting how the response was. It was mostly successful, but of course, always this limitation. For example, COVID vaccine acceptance rate with an assessment, with a study done, was around 50%. So there was still hesitancy of about 50% of the population to again receive, but globally it was about 60%. So it shows, especially the rural population was more hesitant than in terms of accepting, which is explainable as well because of access of information, awareness, and other issues. But it did have a significant impact in building awareness and also trust. In terms of what could be, there's a lot we could have done better, I believe, in terms of globally and also nationally. I think a lot stands out as what we did well in terms of the response, but I think ensuring, especially in terms of lasting investments, I think one of the key areas which I did not speak a lot on is the supply chain, pharmaceutical sector. We have tried to really expand that capacity as a country, but not as much as we should have. Because it was a key pillar and it's the most evident one in terms of human disruption that we have seen. And of course, the financing aspect is something also that I wish we could have done more in terms of sustaining that. But the key one is really in terms of the capacity to have that resilience in terms of supply chain.
Thank you.
Yes.
Yeah, thank you for excellent presentation. I just have one question. I think through your tenure in the COVID and in Ethiopia, there was a lots of competing priorities, especially politically. And if you could speak to that, how you navigated, especially in government, and putting forward all these strategies that help to prevent more catastrophes.
Thank you. Yes, again, leadership, leading in this kind of challenging time, it's always about trying to balance and every time. It's an act of balancing every day. Initially, even our health system was really focused on the pandemic. And we had to quickly, again, correct and see where we are failing in terms of the essential services that could actually harm more people. So prioritizing that was critical even within our system, not even beyond our system. But also it's about giving the right information, having the very strong communication with different government counterparts, because the response was not possible by the health sector and it would not have been possible. And we had, fortunately, under the task force led by the Prime Minister, there were some teams that were led by other ministers. So they were engaged. One was responsible for helping on the resource mobilization, one on ensuring facilities which are not health facilities were being shifted to health facilities, because this will also be of the scope of the health sector. And really giving up-to-date information to them and keeping them on board was a key strategy in terms of having that support, in terms of having leadership engagement, which was key in terms of prioritizing. But it's always about the balancing, and even the economic, which I mentioned earlier, we did not have a huge lockdown not because we were not worried about the impacts of the pandemic, but because the impact of the economic impact would be worse than the health impact. So we also had to balance those priorities.
We have a question from somebody who's online. So, Surafel, would you like to ask your question, please?
Yes. First of all, I want to say thank you as somebody who was on the front lines and felt your presence during the COVID outbreak. My question today is, I wanted to know if there are any changes that you think that were made during the pandemic that have carried on to impact the health system back home in Ethiopia. And if so, like what are like really good examples? I want to base this off knowing that serious stressors like COVID really changed the health systems. We have seen this in the past, and I want to know if, in your opinion, if there is any example that could show us.
Lia, if I may, we're running out of time, so may I ask you to take the second question too, and then maybe wrap up. So Peter, please go ahead and ask your question.
Thank you. Hope you can hear me. Dr. Lia, thank you for that incredible presentation of the breadth of responsibilities you undertook during the pandemic. I'd like to ask for your observations about the position of public health actions and activities within the larger health system. You know, as you know quite well, healthcare facilities and health systems in general are pressured to deliver a tremendous clinical service need. Do you think that the kind of structures that are set up to do the public health activities, National Public Health Institute, now regional public health institutes, are they positioned in the best way possible to deliver this aspect of health system responsibilities? Or how could things be done differently or better? You mentioned that there were gaps that had to be addressed. Thank you.
Thank you. Thank you both, and I guess I may be able to answer both in together, because that's something I can say. One of the lasting efforts that we tried was about the action we took on how do we reorganize the National Public Health Institute. Good ties to the question Rafi asked. Of course, there are different things which I mentioned earlier, be it how we provide emergency and critical care services, and in others in terms of data and research. There are many things I mentioned. In the interest of time, I'll tie, I think, one of these, the interventions that came out from the interaction reviews and the experience through the pandemic was how we approach public health emergency in terms of structuring that nationally. So what we have seen, especially in terms of when we're dealing with the case management or the facilities giving clinical care and the public health response, there was a bit of a silo. So the ministry was the one handling one piece, and the National Public Health Institute was under the ministry still, but handling the most of the public health response. So we had to really merge, bringing alignment into this, and then national, the pre-hospital services and emergency response team, which we call rapid response teams, and disaster management risk teams, were now merged through the new restructuring that we had to make sure that they are responding in conjunction to the same have faster response and aligned response with the same team. So it was a process. It was not an easy process for some of you who may know in the process, because there are territories and people think this is what we should do. But a lot of dialogue and a lot of trying to even have. I remember I think talking to a lot of colleagues even globally on how we approach this, and there wasn't enough examples globally that we could really model on, but we have to use the learnings to modify our approach. So that really is something I think we need to continue to innovate, both in academic institutions and in practical sector today.
Thank you. Thank you so much. That was a wonderful presentation. Thank you so much.